Good afternoon and welcome to the first educational session of 2026. And I would like to thank Dr. Jay Alamalu for agreeing to deliver the teaching today. So Dr. Alamalu is our head of service and also the clinical lead for pediatric hemophilia. So she is an expert in this area. So please feel free to ask her all the questions. I will hand over to you, Jay, so you can start your session. Thank you.
Thanks, Salma. Can you hear me? Yeah, lovely. So I was just going to talk about coagulation disorders, and I'll just set a few slides, and you can always ask any questions if it looks like you want to get a little more information on a particular slide. So I just want to check, can you see my slides?
Yes, but it's not on slideshow, so
Yeah, let me just see. Is that better?
that's perfect. Yes,
Yeah,
thank you.
perfect. Lovely. So we'll just talk a little bit on haemophilia and how we manage bleeding disorders in our service. So basically, we are we are either a haemophilia centre or you could be a comprehensive care centre, depending a little bit on the facilities and the staffing you have in your department. So, as the haemophilia service, comprehensive care service, we look after children with haemophilia, some of the other factor deficiencies or rare bleeding disorders, von Willebrand disease, platelet function disorders, and so on. And of course, in addition to that, we look after the other coagulation defects, thrombotic disorders, anticoagulation, and other hematological abnormalities. So, in terms of the haemophilia side of things, the team is, of course, a multidisciplinary team, and that is really crucial in the management of children with bleeding disorders, as well as, some of the other any of the chronic conditions. So, apart from the hematologist, of course, we need a specialist who really, interact with the families on a very regular kind of basis, and they follow up on a lot of things that are discussed in a clinical setting or after an admission. Similarly, we have a dedicated physiotherapist who looks after these children with bleeding disorders and follow up on any joint or musculoskeletal related problems. In addition to this, of course, we have access to a lot of other specialties where our children need, say, surgery or they need any specific interventions like psychology or dental procedures and so on. So that in the whole kind of makes up the comprehensive care that is delivered to these children. So we see these children in terms of the service itself. So most of this, of course, is very much an outpatient-based service. We manage them in our clinics, but they have access to our teams as and when required. And of course, we do provide 24/7 cover. So there is always access to a haemophilia doctor for advice as needed. The other thing that's really crucial in bleeding disorder services is the laboratory support. And that is something that does determine how we make diagnosis, how we manage, changes in dosing or even, frequency of treatments after a bleed. We have some inpatients that would come in for surgery, mostly for insertion of a line or a portacath. And of course, we have other kind of educational sessions, other events with families. So to start with the, how we manage these children, I thought we'll just do it as a case-based discussion and we'll see how we manage our children. And if you have any questions, do feel free to ask. So I just thought we'll choose a boy who's now about 11 and how we started off with him in terms of the diagnosis and management in the initial years. So this was a very straightforward family history of haemophilia in his uncle. So mum's brother has severe haemophilia. So we kind of knew that this boy has a risk of developing severe haemophilia. So the way we structure these conversations is to often see these mothers when they are pregnant. So we are lucky to be attached to the adult haemophilia centre. So we have the adult hospital in close proximity to our children's hospital. So when the mum presents to the adult side or the adult haemophilia service as a carrier, having being pregnant or even sometimes considering having a child, then we often have a counselling session which also involves the paediatric side to discuss how we would manage the child in the future. So a lot of the counselling begins sometimes even before pregnancy or during pregnancy. So we've quite often seen these parents already. So at the time of the counselling, of course, or if we already know the mother because they already have a child with severe haemophilia or of any severity, really, we do talk about antenatal options for these children, these women. So there is, of course, the free fetal DNA because haemophilia is an X-linked disorder. We could offer something that would detect the presence of the Y chromosome quite early on in pregnancy. And that's kind of in the first few 7 to 9 weeks of pregnancy. And if that confirms the presence of a male fetus, then there are other options to enable testing quite early on in pregnancy. So we do discuss mostly through our adult side, but we do explain some of this to mums and dads so they are aware of their options. So we talk about the chorionic villus sampling, amniocentesis, and when and if they want these performed. There is also a very detailed delivery plan that is made in conjunction with the adult haemophilia team, and that has a section for the mother and has a section for the baby. So with either confirmation that the baby is affected with haemophilia or the potential to be affected if no testing has been done in the pregnancy stage. And there's a very clear plan on how this delivery needs to be conducted, what is to be avoided. Particularly anything invasive is very specifically mentioned. So there is no doubt that, what is allowed. We often have women coming from quite a distance away, so they don't always manage to deliver in our hospital. So there is a very clear plan in the mother's maternity notes in terms of what should not be done, particularly anything invasive, one-twos or high forceps and so on. And there's also clear instructions in that delivery plan in terms of what the baby needs in terms of investigations or how to contact us. And we would generally ask to avoid intramuscular vitamin K until further results are clarified. And of course, with this boy, we knew there's a family history of haemophilia and his grandfather. Mum is a carrier, and his cord blood came back with a factor VIII of less than 1. We would generally ask for a cranial ultrasound, and that was thankfully normal. So the initial advice we give is, as is in that slide. So we would say avoid anything invasive that might cause a problem. Heel prick testing is often a question that's asked by general pediatricians, and we would say that can go ahead, but they just need to apply pressure on the site for a good few minutes, about 5 minutes or so. Circumcision, in some, of course, families, they want early circumcision, and we often have some actually boys with severe haemophilia do not have any problems with circumcision, but we have made some diagnoses because of bleeding during circumcision. So if circumcision is something the families are keen to have done early, then we would of course make sure that we've got the diagnosis and then discuss the need for this to happen within the hospital rather than in a community setting. So that would be something we would discuss. And we would be advising to avoid any intramuscular injections. So the first challenge would be with their primary vaccinations. And that's something we would then discuss with either their general practitioner in the community to be administered by subcutaneous route, or they would just come to us. So our nurses can do this in a safe manner. And as you know, the main reason for this is to avoid the risk of a muscle hematoma. And we've kind of seen that in patients who've not had the diagnosis made already. So this is kind of a draft management plan that women have in their notes. So it talks about what should happen within, for their own sake. So sometimes women who are carriers may also have slightly low levels. So there is a section about the mother and what she needs. And then there is also a section on the baby and what the baby should have done. And of course, our contact details. So all or any queries are directed to us promptly. Right, and once the baby is born and the postnatal examination is conducted, we would ask for a just general check to make sure there is no active signs of bleeding. We often, if the baby is born in our hospital, we would talk about signs to look out for in terms of intracranial hemorrhage, particularly in the severe haemophilia. Although the risk is low, it is still important to be kind of aware, for them to be aware of what to look out for and what the danger kind of signs are, so they seek kind of medical advice fairly early. And as I say, we would normally do a cord blood factor level. And that again is very clearly written in the delivery plan. So there's no confusion on what samples they need to send. Sometimes there is a discrepancy between the cord blood and venous factor levels. That may be either because it hasn't been taken properly. Sometimes it just clots, or they're just not able to send it. And sometimes we do get quite a lot of issues on, the cord blood never went to the lab, or it did, but it got, it wasn't processed, or it just they couldn't get a result. In those situations, we would then ask for a venous sample for the sake of confirmation of diagnosis, because only once we have that can we make it further decisions on whether a cranial ultrasound is needed, or whether baby can have oral or IM vitamin K, and so on. So this baby was born with severe haemophilia, cord blood confirmed. The factor VIII is less than 1, in keeping with the family history. So initially, so this is 11 years back, so practice has changed slightly, and I will come to that. But at the time, we would just monitor this baby. Of course, the first few months of life, there's really, very little risk of bleeding where the baby is relatively mobile. But once he started moving and, kind of cruising and crawling, mum noticed more bruising and some hematomas. And we've always commenced prophylaxis comparatively early. So some guidelines do suggest waiting for the first bleed, and that wasn't what we would do. If we found a bleeding phenotype, as in they were getting hematomas, we would start prophylaxis. And I'm very conscious that that practice may have to be different in different parts of the world in terms of availability of resources and what other factors that may determine when prophylaxis can start. So regular treatment, of course, with factor concentrate or now non-factor therapies would be classified as prophylaxis. And the main idea of prophylaxis is to prevent significant bleeding, particularly in the joints, and maintain joint health. So at that time, he was 10 months old, and of course, with the challenges of getting venous access in that age, he had a portacath inserted. Now, with our in our practice, we are very much keen for parents to be independent and maintaining prophylaxis at home. Again, I'm aware of some changes in terms of that kind of practice in many hospitals or other places I've spoken to. Patients would come into the haemophilia centre to receive prophylaxis by the kind of staff in the hospital, but we encourage patients or parents to be treating themselves at home. And that the aim of that is to improve their quality of life, avoid missing school or parents to miss work and so on. And that's why the Portacath enables us to allow patients to be able to do this at home. So he was commenced on the usual prophylaxis alternate days. This was a standard half-life factor VIII at the time. And of course, the other very important factor here is to ensure there is no occurrence of an inhibitor or to be testing for it. And the UKCDO guidelines suggest that we should be testing for inhibitors or antibodies to factor VIII every 3 exposure days. So every 3rd day of factor, we would be checking for a factor VIII inhibitor test. And we would do that up to 20 treatments have been completed. And after that, we would do it every 3 months for the first 5 years, and then every 6 months thereafter. And that's really crucial to pick up some of these inhibitors, which can otherwise make it very difficult in terms of management. And again, this goes back to the availability of a laboratory that can do these tests on a kind of sensitive and precise level, because once we detect an inhibitor, of course, we escalate treatment, offer immune tolerance, and increase the likelihood of the child still being able to accept the factor VIII treatment. So that was, some time back. So we then had another baby who presented with a very similar kind of presentation, but this was more without a family history of haemophilia. So he was 8 months old, and he had this large kind of hematoma on his chest, which was otherwise unexplained. Often these children, as you may be aware, kind of go through the non-accidental injury kind of pathway because there is no clear explanation. They have a large bruise, and this was something this baby had. The pediatricians rightly looked at that as well, but it was quite clear that his factor VIII was less than 1. So again, he has severe haemophilia. Now, we then have to discuss what the treatment options are for somebody, presenting at this stage where we have other options of treatment. I will come to that. Just come back to this child and what we did for him. So just a very kind of basic kind of background to haemophilia itself. Of course, factor VIII deficiency is haemophilia A, and factor IX deficiency is haemophilia B. Now, we mainly would, we see bleeding symptoms according, of course, to the baseline factor VIII. Now, I've put moderate there as well as, in bold, because we do see quite significant bleeding in moderate haemophilia as well, although they, in terms of, the numbers, they are quite low compared to the severe and mild haemophilia, but they do actually seem to fall between the stools. So we often offer prophylaxis to moderates who have more significant bleeding, particularly the ones under 3, between 1 and 3, they baseline factor VIII of 1 and 3, they do actually have some symptoms. So they would also be included in all our assessments for whether this child or when this child should commence prophylaxis. So in terms of diagnosis, if there's a clear history of haemophilia in the family, then of course, that becomes easier, like I said in the first child. Or if they present with bleeding, that is very typical, as in the second child. And of course, when you do a coagulation screen, we have a very prolonged APTT. Now, further testing, of course, depends on the laboratory, kind of expertise. Factor VIII and IX, I think, is quite widely available. So that should give us an idea of the, whether this is haemophilia A or B. And often we get history where the patients say, oh, we've got haemophilia in the family, but not quite clear whether this is A or B, or it may be not at all haemophilia. It may just be some bleeding disorder or some blood disorder and not haemophilia. So we have to kind of use that information according to what we see from the results as well. The severity of haemophilia, of course, depends very much on the laboratory being able to, kind of do a precise determination of the factor levels. Low factor levels are often difficult to be very precise. So sometimes we see levels in some hospitals that, that are referring to us, the factor 8 or 9 level is 2, but when they actually come to us, it could be less than 1. So sometimes the lower limit of detection, the how specific those tests are can be different. So it is really important there to be able to make an accurate diagnosis. Mild haemophilia B, again, I've just written it there because, of course, babies are often born with low factor 9 levels, and that is physiologically normal. So it is difficult to make that diagnosis of mild haemophilia B soon after birth. In this case, genetics, helps. Of course, if it's available, fantastic, because it will, of course, take a few weeks to months for this result to come back. It also helps in severe haemophilia in the sense of just understanding what the actual mutation is. There are some mutations that have high risk of inhibitor development, and that gives us some idea of avoiding some of the environmental factors that we could in reducing the risk of haemophilia, of inhibitors. So management, mild haemophilia, they often respond to desmopressin. So we would offer a trial of desmopressin in about the age of 5, and we do it by subcutaneous route. They don't get that many reactions to it when we do it subcutaneously. And if they bleed before the age of 2, then we often have to use factor concentrate. But generally, they're not very symptomatic. Of course, they can still fall and have significant joint bleeds, in which case treatment is required. And we have the same principles in terms of avoiding contact sport. And of course, the definition of contact sport is a slightly, bigger can of worms in terms of, how careful we want to be with our children, but equally balancing that with their quality of life as well. For any mucosal bleeding, we would ask them to take some tranexamic acid. Our children always have are meant to have some tranexamic acid at home for use as required, and that's usually, as it's an antifibrinolytic, so it helps with clot stability and is very useful in mucosal sort of bleeding and also in surgery. And of course, if they have any significant bleeds or they require complex surgery, they would have factor concentrate itself. So I will come to the prevention of bleeds in the next slide, and that's basically prophylaxis. So prophylaxis is that's the initial definition of prophylaxis was intravenous administration of factor, but of course that has evolved slightly now because it's not just intravenous. We have subcutaneous non-factor therapies that are also available for prophylaxis. But the gold standard, of course, in most of the definitions of the different organizations is still factor prophylaxis. So why do these children need to be on regular treatment? And this was the pivotal study that was done in 2007 by Manka Johnson, and basically it looked at 65 boys who were randomly assigned to either receiving prophylaxis or not receiving prophylaxis. And the study actually, they had to kind of end it early because there was quite a stark difference between the two groups. And you can see the difference in joint bleeds. So 0.6 when they had prophylaxis versus 4.9 when they didn't have prophylaxis. Similarly, in the number of bleeds, 17 without prophylaxis versus 1.2. So that made a huge difference to how people viewed the need for prophylaxis in these patients. I mean, there were some other, quite interesting things that came out in that, it also looked at whether patients reported a bleed, and they also did MRI scans, and they found that joint damage was also seen in patients who didn't report a bleed. So it was the whole concept of whether there are subclinical bleeds in joints, even with those on prophylaxis. Of course, the way they did prophylaxis was slightly different to how we do it now. So hopefully that means that our prophylaxis now is more robust in preventing these bleeds, despite being on prophylaxis. The next question, so we know prophylaxis is essential. So those with severe haemophilia, and of course we also have some evidence in moderate haemophilia, so we know it is essential they need to be on prophylaxis to prevent joint damage. And then the next question comes to, when do we start prophylaxis? I mentioned in our case study that initially we did it at 10 months of age is when we started talking about prophylaxis, because the boy was bruising. And then with our second one, he's 8 months, and then we are at that crossroads in terms of, should we start prophylaxis now? And this was the paper looking at the long-term joint scores in children who started prophylaxis at 0 to 2 versus those who started slightly later. And you can see that the proportion of patients with a joint score, so this is the haemophilia joint score, low is better. So if you have a score of 0, that means your joints are pristine. The higher your joint scores, and this is usually done by our physiotherapist, of course, depending on availability of such specific individuals, or it can be done by the clinical team. But basically it looks at various parameters of joint health, looking at crepitus and movement and so on. And based on that, the scoring was much better when prophylaxis was started before the age of 2. So that again gave us enough confirmation that early prophylaxis was key to long-term joint health. So with that in mind, we have more recent guidelines that look at what options we should be offering to our patients. So we talked about when to stop prophylaxis, so earlier the better, and then which product. So we have options to treat children in haemophilia. So we have factor VIII replacement therapy. Of course, in haemophilia B, that is the only option. We just have factor IX replacement therapy. In haemophilia A, we have factor VIII replacement therapy, which could be plasma-derived or recombinant. We don't use plasma-derived in UK for children, without a very specific indication. So generally, they would all be on recombinant factor VIII, and that could be either a standard half-life factor VIII or an extended half-life factor VIII, and that is of course on convenience, because you have fewer doses with the extended half-life factor VIII, or they could be on non-factor therapies. So that would be emicizumab, that is currently licensed. So this gives us that option in terms of what we want to choose. And of course, one of the main limiting factors for haemophilia, for factor therapy, is administration through IV access. And as I said, a lot of our children would then have had a portacat, and then we train the parents and they then administer this at home. Of course, this is not easy. They need a general anesthetic, risk of infections, and it's not very easy for the child. The portacat, every few years it can have a mechanical problem. So all of those are, of course, the issues with factor therapy. But of course, on the other hand, it can be used for treatment as well as prophylaxis. So a lot of benefit in being able to treat an emergency at home. So the option is, of course, emicizumab, which is a factor VIII mimetic, and the main advantage for this is, of course, it can be given by subcutaneous route. So you don't need general anesthetic, and it's much easier to administer. You don't need a whole paraphernalia of portacat stuff. But of course, if there is a bleed on emicizumab, you still need factor VIII if it's a significant bleed, so they do need to go into hospital and have this administered. There is also now the availability of an ultra-long-acting factor VIII, and this is called FNS octocog alpha. And this is very similar to the extended half-life factor VIII, but lasts even longer because of the unique structure and mechanisms of improving its half-life. So this is not available, well, it's not licensed in children under 2. So at the moment, this is only for slightly older children with severe haemophilia. However, it's still very promising in that we have all these options now. So if we go back to the second baby I talked about, so that was the 8-month-old who presented with severe haemophilia, we discussed various options, all of those I mentioned, and the family chose to go for emicizumab because it was just much easier for them. They didn't want a general anesthetic, and he still remains on emicizumab at the moment, and he's doing very well. So just to kind of finish off with haemophilia. So I've only talked about haemophilia A there, but haemophilia B is fairly similar. We do, they are meant to be slightly less severe than haemophilia A, but we still have children that have had intracranial hemorrhages on the day of birth. So we still offer the same level of intense prophylaxis for haemophilia B patients as well. So I will just move to this young girl. So she is now 14 years old and presented with mainly menorrhagia. So her periods lasted for many, many days, very, very difficult, very tired, often missing a lot of school, had a bit of bruising, but otherwise okay. Mum also had very, very heavy periods. So with this history, we would look for a primary, of course, hemostatic defect. So she had the general coagulation testing, including von Willebrand factor and a platelet function screen. Now, her von Willebrand factor was slightly on the lower side, and this was very much in keeping with type 1 von Willebrand disease. We see this very often. Again, von Willebrand testing can be quite tricky in if the laboratory isn't set up for it. And there are various factors with von Willebrand testing. It goes up when children are distressed, or if they've had surgery and so on. So again, repeat testing is often necessary, and it's not often easy. But in any case, with this girl, it seemed to be in keeping with type 1 von Willebrand disease. So most of them will present with just minor bleeding symptoms, mucocutaneous bleeding, generally heavy periods, as with this presentation, and coagulation screen may be normal, or sometimes the APTT is prolonged if the factor VIII is suitably reduced, and you just need to test the von Willebrand antigen and activity. Multimers are used to differentiate between type 1 and type 2. And genetics helps as well. So of course, type 1 is a quantitative defect, whereas type 2 von Willebrands are qualitative defects. So if you have a discrepancy between the antigen and activity, that may suggest a type 2, and further testing then would be required to then differentiate between the different type 2s there. And of course, type 3 is complete lack of von Willebrand factor, and they essentially behave like severe haemophilia A, and that we treat them again with prophylaxis. So as said here with type 1, again, they respond to desmopressin often, and we would use that for the general treatment of bleeding. Type 3s, they are on prophylaxis. So type 3 von Willebrands, they will go on von Willebrand factor concentrate, very similar to the first case of haemophilia A. We put in portacats if needed, and they are treated with von Willebrand factor concentrate. Of course, we still use plasma-derived von Willebrand factor concentrate for prophylaxis because the recombinant von Willebrand factor is not licensed for prophylaxis. In terms of menorrhagia itself, again, it can be quite distressing for the girls. I mean, sometimes they miss days and days of school. It's very embarrassing. It's very, they get very tired. They pass clots, and that can be quite difficult for teenage girls. So we would ask them to take some tranexamic acid, and of course DDAVP if that works, but generally we get them into a gynecology clinic for advice, and they often commence on on some sort of hormonal therapy in order to kind of control the periods. And as I said, prophylaxis in the severe category. Okay, just moving on to the next one. So this is a 7-year-old girl from Pakistan, and she was premature, and at the age of 3 days, the cord stump started to bleed. And she then had muscle hematoma after her vaccinations, and unfortunately, at the age of 2 months, developed an intracranial hemorrhage. So there is history of consanguinity. Parents are cousins. So she had the routine investigations, and she had further factor assays because the coagulation screen was abnormal. Both the PT and APTT were very prolonged with a normal fibrinogen. So testing then would be for prolonged PT and APTT. We would look at factor 2, 5, and 10. Initially to see if there is an explanation, and her factor 10 level was less than 1. Now again, some of these factors are quite difficult to obtain in routine labs. So again, it goes back to the need for a very specialized kind of reference laboratory to perform these assays. Now in the context of an intracranial hemorrhage, she had a neurosurgery opinion, initially treated with FFP and tranexamic acid, and then she's had factor concentrate. So we do have a factor 10 concentrate initially. If there is no concentrate available, you treat with FFP, and you can use PCC to provide the factor 10. The problem with FFP or PCC is you cannot be very sure of how much factor 10 each of those bags contain. So it is a little bit difficult to work out how much you have actually managed to correct. Unfortunately, we now have a factor 10 concentrate. So the aim would be to maintain those factor levels in the normal range. For any child with an intracranial hemorrhage in the presence of an underlying bleeding disorder, we would normally treat and keep them at normal levels for about 2 weeks, and then carry on with regular treatment and prophylaxis. Now, in this situation, she actually couldn't continue with prophylaxis and then had a second bleed. And then she came to us here, and she's, remained on prophylaxis and managing not to have had any further problems. So these are rare bleeding disorders. Most of them are autosomal recessive, in which case it's mainly consanguinity in parents that would lead to a severe disorder in the child. And just a quick mention about factor 13 deficiency. You can get factor 13 deficiency in the context of a normal coagulation screen. So it's just, kind of being aware of it. So with, again, diagnosis management, most of this with a family history, and then you do a coagulation screen and the specific factor level treatment. So tranexamic acid we use throughout all bleeding disorders, and then very specific concentrates based on which factor is deficient. We have factor concentrates for factor 10, we have fibrinogen, but there's no factor 5 concentrate. So that depends on what is missing. So lastly, this is a 7-year-old girl. She's born by TAM and no initial bleeding, but then she bled a lot after her vaccinations, and then she had some, at the age of 2, she had a upper respiratory infection and had dark stools. So she was seen in hospital and actually was very anemic. And initial testing showed an abnormal platelet function screen. So she was treated with a blood transfusion and platelets as well. So if you look at her kind of family, dad is Ghanaian and mum is from Guatemala, so obviously not related. As I said before, a lot of these children do have non-accidental injury investigations in the context of, no explanation. But anyway, so her initial testing was not particularly impressive, but she had products just to, make sure that things were corrected. But actually on further testing, so these are, detailed platelet function testing, she had platelet glycoproteins, which showed a reduction in the GP3A4. Aggregation again showed no response except for astacetin. So we did more genetics and confirmed that she has Glanzmann's thrombocythemia. So again, this is a severe platelet disorder, which can be quite tricky, especially in a girl. So she's still prepubertal. So the next challenge for her would be when she starts her periods. So just a summary of platelet aggregation. They can be quite, they're very difficult to perform, very labor intensive, and takes a lot of effort on the laboratory side and a lot of blood for testing. And in that context, she was confirmed to have Glanzmann's. So most of the platelet functions can be fairly mild, but Glanzmann's and Bernard-Soulier can be severe, and they may need platelet transfusions in order to control certain bleeding events. So those were a general kind of overview of bleeding disorders, and what's most important here is as an MDT approach with a lot of specialists involved based on what happens with the child. So that was a quick summary of how we manage our bleeding disorders in our service. Thank you.
Amazing. Thank you so much, Jay, for a comprehensive run through many different bleeding disorders and how you manage, and then highlighting simple testing versus specialist testing, and also collaboration between different specialties such as maternity and even within your MDT. So for those who have maybe joined us a bit later, Dr. Alamelio is an expert in bleeding disorders, hemostasis, thrombosis. So I would encourage you to ask questions, whether it's about her talk now, or if you would like to discuss any of your cases. Any comments or questions, please unmute and go ahead. Has anybody got any questions to ask or anything to say? Maybe I can ask if anybody from the call is from the UTH site, because when we were there in September, we did discuss a very interesting little boy with a very low level of factor 9. He had some intracerebral hemorrhage and required actually some ventricular shunting. And we did say that we're going to get an update in one of the future MDTs. So if anyone here is from the UTH site and knows about this child, perhaps they can give us an update. Perfect.
Good afternoon, Summer.
Hello. Good afternoon.
I'm not sure if we're thinking of the same patient, but was it an infant who needed a shunt, ventricular shunt, and had intracranial bleeding, and they're thinking has TB as well?
I cannot recall the TB part, but yes, it was around the September visit.
I think that's the one who actually had the shunt. Unfortunately, I think he returned sometime later on in October, November, and he died. Yeah. He had some massive bleeding going on, and he died. Because his shunt malfunctioned and he needed a new shunt, but then they couldn't go in and the bleeding was ongoing. Unfortunately, we lost him.
Could I ask, did he receive any factor treatment at the time of his shunt insertion or revision?
Yes. So the next time when he came, when I got a chance to attend to him, he was on factor replacement therapy. Yeah, he was on it.
I think due to availability, he gets once a week, isn't it? I think most patients in Zambia, they get just once a week replacement. Is that right?
For him, yes, they do that. They do. But for him, he was on a daily dosing because of the massive bleeds he was having. So he was taking it every day during his admission.
I think they can be quite tricky. We had our first, at least my first, when I became a consultant, one of my first experiences was a boy with severe haemophilia B who presented on the first day of life with an intracranial hemorrhage. And it's come a long way. He's, I saw him last week. He's 40. He's 13 now, and he's kind of, we're looking at things like gene therapy for him. So he's just getting into the gene therapy trial. So yeah, a lot has changed over time, but it also depends on how lucky or unfortunate they are at the time and how quickly treatment can start, so that it can at least kind of stem that bleed right in the beginning. But of course, not everything is straightforward or goes according to plan.
Yeah,
Very, very sorry for your patient here.
I had a question though from your presentation on the use of desmopressin. In your experience, because I think I've only seen 1 or 2 patients who use desmopressin in our setting, and they're using intranasal. I think one of them has von Willebrand, so she uses intranasal. So in your experience, which of the two is intranasal still almost as good as the subcut version? And is it that the patient develops tachyphylaxis sooner than the subcut? And how best can we avoid them getting the tachyphylaxis?
Yeah, I mean, we were using intranasal until it was not available anymore. So I think about even before, I think it's been a few years where we haven't had access to intranasal DDAVP, the Octim nasal spray, because I know that there are different, the Desmo spray or something, the one they use in nocturnal neurosis. So that, of course, the dose is very different. That's, I think, only 20 micrograms rather than the 300 micrograms we would normally ask for our patients to take. So we then stopped using nasal sprays only because it was not available in the strength that we want the 150 micrograms per kind of spray dose. So when we were using it, it was very effective. It was very expensive as well. So we didn't really miss it very much. So often we would give it to girls to keep and use at the time of periods. But as I say, that just wasn't being available. It just wasn't available anymore. So we've switched to subcutaneous DDAVP. Now, I mean, we have many. We do a DDAVP test on almost all our mild haemophilia and von Willebrand and platelet function disorders, just to document response, and we use it for surgery or any bleeding problems. I would normally ask them not to repeat it within 72 hours to avoid the tachyphylaxis and because they just reach that plateau, and after that we don't see any response. If there is a situation where we think the response is needed for a prolonged period, we have sometimes done, we had this boy with mild haemophilia who was going away to Egypt on a very, a wonderful holiday that they'd been planning for years. And then, of course, he had a bleed just before. So we then gave him factor before he went. But while he was there, it was easier for them, the family, to just do DDAVP. So they just kind of did that and then came back here. And then we kind of did a little bit of, alternate this and that, so that we're not kind of hitting that plateau. But yeah, we've just done that. But generally, we wouldn't use it repeatedly to avoid that, the tachyphylaxis.
Perfect. Any other questions?
Hello. This is Dr. Chira from UTH. I'd like to find out what tests do you do for inhibitor testing? And then secondly, are there any factors that may affect the inhibitor testing results?
So we do the NIMEG and Bethesda for inhibitor testing. The other thing we have to be aware is, of course, those on emicizumab. We do the bovine Bethesda. So it's just, I think one of the main factors then that affect the testing is one, the baseline level. So if they have factor on board, so we would want to do it on a trough level day, so at their lowest level. So we would generally do inhibitor testing on the day they're due their next dose, so that their baseline factor has come down to definitely under 5, and then we can just do their, Nijmegen and Bethesda. If they're on treatment or they've had some treatment the day before, then we kind of push the testing to a day when they're at least, depending on which product they're on, we would push it to a day when it's come down to their baseline level, and then do the inhibitor testing. If they're on emicizumab, then we just do the bovine Bethesda, because as you know, otherwise your APTT, the emicizumab will impact on the APTT based, just even simple inhibitor testing. Other things for the mild Haemophilia A, we do a heat-treated Bethesda. If there is a little more factor 8 in circulation, then they heat treat it and leave it for 30 minutes and then do the Bethesda testing. And that picks up some of the inhibitor, especially the type 2 kinetics, where you can have residual factor 8 as well as an inhibitor present. So that is useful in the milder patients where it's trickier to find an inhibitor, even though they are there. The other thing we do is recovery testing. So, as you know, with inhibitors, even if the Bethesda is quite tricky to do, we could look at the trough level itself, because if the trough is much lower than what we expect, that is, of course, one of the kind of danger signals. The second is the recovery. So, just very simply a pre and a post level. We don't do it all the time because I think the boys don't really want to stick around and have another test done and so on. But we try and do it as and when we can. But if we did a pre and a post, and if we're getting a good response as we would expect, so over that 66% recovery, then again, that's a surrogate marker that there is no inhibitor. But ideally, we should be doing the Bethesda testing for them.
Okay, great. Thank you so much. Then secondly, do you have any experience with use of gene therapy for hemophilia B?
So we're currently doing a clinical trial. So that boy I was talking about with the who had an intracranial hemorrhage that many years ago, we've just recruited him in last week to join the gene therapy study. So he's not yet we're still waiting on, all the numbers and so on in terms of being able to for him to get the tick to join. But that is something. So this is the Hemgenics, which is already licensed in adults. So he's in the 12 to 18. So that is the next level of gene therapy trial. That's in the 12 to 18-year-olds. And I know Neha is on the call, so their centre is also part of the same, we have the 3 UK centres. So we're very excited to see how this will work out. But of course, it's the AAV5 vector, so we are waiting to see, just making sure that he hasn't got antibodies, at high levels to this. Hopefully he doesn't. But then dosing will be in about 6 months from now. So we're very excited about that. So we'll just have to wait and see how it works in younger children, in younger people.
Yeah, that's exciting for sure. So your cutoff age is 12 years, right?
So for the trial, it is 12 to 18, yes, yeah. And it's a 5-year follow-up. So, of course, they've got, I think, even in the adults, 5-year data is available. But so it's something to watch.
Absolutely. That's exciting. Thank you so much.
Great, exciting times indeed. Okay, have we got any other questions or comments from the Zambian team or the UK team? We've got a few UK representatives today. And perhaps we could actually welcome Dr. Neha. She's joining us. Neha, would you like to introduce yourself?
Yeah, so my name's Neha. I am a pediatric hematologist at Oxford, and I work in pediatric haemophilia as well as pediatric hematology oncology. So thank you for inviting me to be here today.
Great, thank you for joining, and perhaps we can entice you to do one of the future presentations in your area of specialty. Thank you.
Cool.
Fantastic. So if there are no further questions, we may end. Subhana, your camera's on. Did you want to say something?
No,
Great.
just say nice to see everybody, or some of you who have your cameras on.
Perfect. Thank you. And please do give us some feedback. The feedback form is in the chat. It takes, I think, less than 2 minutes to fill. And we are going to meet again, same time, third Monday of every month in February for our second session of 2026. Thank you very much.